All right.
We're live.
We're live. Hi, everybody. Welcome to this second or third edition of Lunch Lab. I want to introduce Dr. Ethan Cement, Dr. Michael Collins from Chelsea Foot and Ankle, and we'll be talking all about bunions today. I'll let you guys take over.
Thanks for having us. All about bunions. So I guess we should just jump into it because we want to leave lots of time to answer questions and have discussion.
I love bunions.
I love bunions too.
I
don't love my bunion, but my bunion's really it's a baby bunion. We're keeping it as a baby bunion.
I just have hammer toes. I'm pretty blessed. I'm not having bunions, so that's nice.
But bunions are part of the normal range of abnormal things that we find. And so I think it's important. I think people get stigmatized by the term bunion. I think people of my dearly departed grandmother's age, she'd now be 100 and something, they stigmatize the term. And I've noticed that there's a trend with a lot of healthcare providers who like to talk about arthritis at the big toe joint because they're deliberately trying to not use that term. And I think it's unfortunate because we should just own it. It is what it is. Or I've had patients, I'm sure you have too, who come in and say, I don't have a bunion. I have something called hallux limitus. Right, you've got an advanced form of a bunion. Excellent. Well done. And so let's just go through the basic
The anatomy of it.
Yeah, why don't you start off with all that,
sure.
We'll just sort of go from there.
So when a patient comes in to see me, I generally like to keep in mind what the normal anatomy of the first ray looks like. The people think that the bunion is just a bump on the side, but actually it's more involved. You need to look at the first metcuneiform joint, you need to look at the actual metatarsal itself, its position, then the first MTP joint, and finally the hallux, where it's at, what its position is. A normal joint is going to be in alignment, there's not going to be any deviations. Thank you.
I'll be here.
I'll be here. So, this is usually straight, maybe slightly some abduction in the hallux. And then when you're looking at it from the lateral view, you want to make sure that the first metatarsal is not either raised or plantar flex when compared to the rest of the metatarsals. Once you kind of have this normal anatomy down, then you can start to look at any deviations from that normal anatomy. One last thing I forgot to mention is sesamoid position. A lot of people think that the sesamoids are moving. It's actually the metatarsal is moving. The sesamoids are staying in place. So like I said, once we have the kind of normal anatomy down, then we can go down, then we can start to discuss some of the abnormal anatomy.
This person doesn't have sesamoids.
They do not.
Just not. This is a very unfortunate example.
So I when I go through my physical exam, I obviously like to look proximally, then work my way distally, even if they're coming in with a complaint of a bunion. I like to put that first MTP, first TMT through a range of motion, so that middle cuneiform and the first metatarsal, to see how much flexibility there is there. If there's a lot of dorsiflexion and plantar flexion, that tells me that there's a lax TMT joint, and that could be the driving force of your bunion. Then I go distally, and then I want to assess the bump, feel if it feels like it's really prominent and hard, or if this is something that feels like maybe it's just capsular hypertrophy or some type of soft tissue. And then putting the MPJ through range of motion, and finally the hallux position. And I think that once we have all that clinical information, then we need to switch to taking x-rays to really assess the deformities on a radiographic level. And I think once we have all of that information gathered, then we can come up with a treatment plan, whether it be conservative or surgical options.
The radiographic assessment of a bunion is imperative, and I think there are a lot of people who skip on this because they take one look at the foot and they go, you got a bump there at the first MTP joint, so you've got a bunion. No, you don't, because a bump does not a bunion define, for sure. We have seen it, I'm sure you've all seen it in your practice, that somebody has this enormous looking bunion, and we take an x-ray that's like normal IM angle, normal HA angle. They just have this really, really large hypertrophic joint, but it's actually aligned and it's functional. So now what do you do about that? Well, they've got this joint and it may be bothering them for other reasons. There are a lot of differential diagnoses which we'll cover. But the other thing about the radiographic assessment of a bunion, and this is something that is unfortunate, for most of these, most of the radiographic centers that we see people going out for radiography,
Not weight bearing.
not weight bearing.
I knew where you were going with
It's
that.
absolutely, and particularly when you're trying to do, well, so when you're doing a trauma assessment and you're trying to see if somebody has a fracture, they have to be weight bearing. Even in the pain that it causes, you have to get them comfortably to load themselves into a position. And then the x-rays need to be shot properly, which unfortunately a lot of radiology suites, they'll try to do a simulated weight bearing, so they'll have the patient laying down, which automatically, now they're not in angle or invasive gait, and they'll load a plate up against their foot, and that loading can evert or invert the subtalar joint. So all of a sudden, everything looks really wonky, potentially. And then on top of that, if you're looking for a fracture of any sort in trauma, you're not going to see it because it's not actually, the fracture is not being necessarily distracted because of the weight bearing. So from a pure total assessment, I have patients, we all have patients who come in and like they're really concerned about the cost of things and like maybe they're self-paying because their insurance doesn't cover it. Like I really don't want to pay for an x-ray. And my answer is, that's cool, I really can't give you a full assessment without looking at one. And that's just the reality. Because no two bunions are the same. No two bunions within the same patient are the same because our feet aren't the same. And that's a really important, that's an important thing for us to always drive home. And because no two bunions are the same, they aren't treated the same. And that's, I think, really what we're going to talk about is how we treat them.
I think a lot of people hear the word bunion and they automatically jump to surgery and they hear the horror stories that, that their friends or family they've experienced with, and that doesn't, I think that's true. Not every bunion needs surgery. A lot of bunions can be managed without surgery.
Absolutely, and let's just talk about the horror stories that people hear, that they had surgery and their toe is hurting worse than it was before. And so I wanted to sort of unpack that for a second, because I think that there are a lot of really awesome physical therapists and allied healthcare professionals in the city, and there are a lot of them who are just doing it all wrong, and we all know this, right? And the reality is, much as it makes them really uncomfortable to say this or hear this, but I'll put it out there for the world to hear, there are some really good surgeons out there, and there are some really awful surgeons. And there are some really great surgeons who are doing wrong procedures on our patients too. And that's something that we need to talk about. When people have, as a general rule of thumb, if you have a painful bunion that is not responding to conservative care and you end up resorting for surgery, you tend to overall have a better response to surgery than people who are coming in and having this done because I just don't like the way it looks. It doesn't fit properly in my shoes, and by shoes we mean stilts. And it's actually a decision that I personally made. I've never actually even asked you whether you do this or not, but I made a decision years ago that I absolutely refuse to do cosmetic surgery on patients anymore in the foot, because in the absence of pain preoperatively, the pain that they experience postoperatively is enough to trigger them and throw all of their mechanics off for like months and months, and that, if not years. And so that's something that I made a personal decision, that in my opinion, personally for myself, that goes against the do no harm part of things here. So
I agree. I mean, that's always my first question. How much pain? Is this causing you pain? People will come in and say, I just don't like the way it looks, or like you said, it doesn't fit in my shoes or my stilettos or
Right.
5-6 inch heels. Like, okay, but does it hurt you when you're just walking around every day? If they say no, then it's something that I'm not, okay, well, unfortunately, I don't think that we will be the right fit because I'm not going to do surgery on you if this is not something where you have tried and failed conservative therapy and you're just in pain.
And that sort of model of patient who comes in for that, it's typically more female than male, but bunions are typically more female than male. So there was a really interesting study in the journal of, I think it was the Journal of Foot and Ankle, I forget what it was. I have it. Foot and Ankle Research, yes, 2010 study. It was a meta-analysis of 78 different study groups over 76 patients. And what they found in this 500,000 cohort patient study was that bunions are, in fact, more common in women than men. It's about 23% on average of the population. But then they go into this statistical analysis and show why this is an incredibly hard number to capture and why there's a lot of variability with this, even within that sort of cohort meta-analysis study. And that it's much more common the older you get. And so that in patients who are 18 to 65, it's 23%. But then when you look at patients who are over 65, it's magically 38%. Like, well, how did that happen? Well, as we all know, our foot changes as we age. And so specifically, it's the effect of gravity and other factors on ligamentous laxity. And so while our foot stops growing at skeletal maturity, which for most young women, they say it's 17, although I'm saying it's like way younger nowadays. In my practice, I'm seeing skeletally mature women at the age of 15 and 16. And in men, its textbook answer is about 18, although I'm seeing it in young boys who are 16 to 17, so things are changing. And what you find is that just the impact of weight, activity, and gravity on the foot causes things to splay out. And that gives your foot an increase in width as well as length as you get older. But most people come in with shoe fitting issues. And it's really ironic that a lot of bunion issues that come in to see us are people say, I've been a size 10.5 since I was in high school. I'm like, well, there's the problem. like you're not a 10.5. You put them on a Brannick device and they look at it and they go, 12, huh? I'm like, yeah, it's going to get really interesting when you hit over 40, trust me. I started off in college wearing like a 10.5, 11. I am now solidly wearing a 12.5, 13. That's just my foot is splaying. That's life, it's not a big deal. And the effects of estrogen and progesterone on the body and on the ligaments are far more conducive to ligamentous laxity than testosterone is on men. And specifically, this is something that actually we get to see in our trans patients, which is really interesting, that when they start taking hormone therapy, and specifically male to female patients, they actually start really developing more ligamentous laxity, which is not what somebody who started off biologically as male and then is transitioning to female wants, a bigger, wider foot. No one wants a bigger, wider foot. So that becomes like an issue. And our practice statistics on this actually are bearing out a similar finding, although not exactly the same. We try to figure out why that was. Michael and I were going through the numbers. We think it's also because we skew to a younger population and that we tend to deal with people who are pretty physically fit, a lot of athletes, and there's also a sampling error in our population in that we were going by billable diagnosis in our data, and there are a lot of people who we're billing them for sesamoid fracture or something else where hallux valgus isn't a billable diagnosis or hallux limitus, but in fact they have one, it's just not being captured. But we're still seeing the female to male population shift, and it's following the average. As far as conservative care, let's get into treatment, right? As far as conservative care for a bunion, my personal approach is start with the shoes and start with the sneakers, because 9 times out of 10, that's the problem. 9 times out of 10, they're trying to wear something that wasn't designed for their foot type. And if you can educate people to get into a shoe that is appropriate both on width and length, and specifically when it comes to physical activities, wearing a sneaker that fits them properly, you're halfway there, actually. And you don't typically necessarily need to revert to an orthotic, although that was the way that I was trained.
Same here.
Sure, you were trained the same way. And I think that's a reflection of both an old way of doing this, as well as the fact that we are still in a for-profit healthcare system, and orthotics for most podiatrists and orthotists and orthopedic surgeons tends to be a for-profit item. So when we removed that need from our practice, it made it easier to free us up to see how people did with adaptations like physical therapy, which is another way that we send people all the time to sort of deal with this. Joint remobilization, working on stability and intrinsics, and really muscle activation, and getting people to recognize that the foot, acting as a passive platform for things that should be happening higher up the kinetic chain, that's the name of the game here, and that's where a lot of the compensations come in. like flexor substitution and stabilization and about that peroneus longus, which we haven't even talked about yet. You want to talk about the peroneus longus?
Yeah, sure. So the peroneus longus. Why not? So the peroneus longus, it starts in the lateral aspect of the leg, goes down, dives deep into the foot, and then attaches at the proximal portion of the first metatarsal, or the medial cuneiform. And that really helps with plantar flexion of the first metatarsal. And I think that when that is weak and you really aren't engaging that, what can happen is this can elevate. And that right there can lead to a whole slew of other problems.
Yeah, specifically like the form, like hallux limitus, hallux rigidus, stuff like that. And I think a lot of people miss the role of peroneus longus in the development of a hallux valgus etiology. Hallux valgus being, for people watching, hallux valgus being the medical term for a bunion, where hallux, the big toe, goes into valgus, which is a slight sort of inward rotation, and sometimes abduction as well. What we're really talking about is the involvement of the subtalar joint and the interplay between the subtalar joint and the peroneus longus. And so for the longest time, the theory, or I should say the argument behind orthotics working on this was, well, if we can restrict your subtalar joint range of motion, and we can give you all the eversion or pronation that you need at the subtalar joint, but block you going from that necessary range of motion, because we all need to pronate, that's how our foot functions when we walk, blocking that excessive range of motion into hyperpronation and hypereversion, that then helps with keeping the peroneus longus from over-pulling and then this cascade of events sort of kicking in. It's an interesting theory, but the data doesn't completely bear it out. And this is something that a lot of our colleagues in podiatry just don't really like to talk about, but we do. And so when people come in, and we all get that patient who's like, wants the data. And I'm like, well, the data isn't there. And study after study, the data isn't there. I can give you anecdotal evidence. I can tell you that with my own bunion, because I x-ray myself every 6 months for fun, just to make sure the machine's clean and stuff like that. I can tell you that since using orthotics, my bunion has stopped progressing. It's just completely stopped progressing. That's not why I started using orthotics, but it's something that's kind of neat, and it doesn't really bug me anymore. That's also neat, but there are also other factors as why it doesn't bother me. I think that, when talking about using that, we have to also ask ourselves, what are we doing by restricting subtalar joint range of motion, and how is that playing up the chain in that specific patient who may or may not have knee, hip, SI joint, low back issues, and all the way up the kinetic chain. So there has to be a valid reason to want to try to sort of limit that subtalar joint eversion. Now, I mean, if we're talking about somebody who has like a near rocker bottom foot, yeah, I mean, you've got to do something, and you've got to get in there. And I don't think any of us would argue that giving them some sort of neutral movement towards neutral, wouldn't be a good idea. But orthotics, while they are part of the conservative discussion about conservative care of a bunion, they're not necessarily our go-to.
They're not my go-to. I tend to have the shoe gear modification conversation, and a lot of patients, though, they are very resistant to that, especially people who like to wear fashionable type of shoes that tend to be narrower. That's an uphill battle. And then when I start to introduce the thought of physical therapy, they're like, well, what is that going to do for my bunion? How is that going to change it? I'm like, well, it might not necessarily make the bump go away, but what you're doing is you're strengthening your foot, you're strengthening the intrinsic muscles, you're strengthening the calf muscles, and that's going to help prevent it from progressing. I would say that orthotics, usually I reserve those for people with like posterior tibial tendon dysfunction, who have this severely like rocker bottom type of foot. I don't jump to, but orthotics I think for bunions right away.
Yeah.
It's usually later down the road.
And it's a shame because a lot of people who come into us for bunion consultations who have seen other doctors come in and say, well, I've already had this, I've had a cortisone injection or 2 or 3, and I've had an orthotic. And and you're still sitting in front of me in my office. So
three or four
pairs
of orthotics.
Always, and they always cost way too much, even though we all use the same like 10 labs and we know what they cost, so now we know what their markup is. And that's problematic, right? Like that's problematic, and again, that's a for-profit healthcare system influencing care, which is a problem. But when I think about it in terms of my go-to on treating bunions conservatively beyond shoe gear, it's actually physical therapy. I'm not saying that because I'm sitting here talking to a physical therapist. I'm saying that because I actually think it works, because the evidence in my practice bears out that typically what happens in physical therapy, aside from capsular mobilization, soft tissue mobilization, mobilizing the sesamoid apparatus, and getting intrinsics to start firing, typically what happens is that with a good physical therapy group, you're working up the chain, and then you start to identify other issues that are causing overload of the first MTP. And that's where you really start to make differences and gains. But there are people who do corticosteroid therapy for this, and that is really end-stage palliative in my book before you end up doing surgery.
Yeah, for a bunion, I don't think I've ever given a steroid injection just for a bunion alone. If there's severe hallux rigidus, where you're getting very small amount of micromotion in that joint, and they just need to get through their day, and they don't want to have surgery, then I'll offer them one, and then they usually find they have a lot of pain relief. But just a bunion itself, yeah, I don't.
And as far as like contraptions, people get those toe spacers, people get the bunion shield. We sell none of that in our office. We endorse none of that in our office because it's not evidence-based. And if somebody comes in here to my office and says, I don't know, it's a 34-year-old runner, and says, I put that toe spacer between the first and second toe, and I put the shield on the outside of the bunion, and I have no pain when I run, then my answer is, then do it. Like, if standing on your head, I say this to my patients all the time, if standing on your head and singing the national anthem works, do it every day and don't miss a day. I don't care what works for you. I just want you to understand that there's no science behind that. But hey, the placebo effect is 30%, and 30% is better than 0. So if using that works, do it. Yoga toes, you like the way yoga toes goes? That means you're not stretching. Okay, cool. Do yoga toes. That's a passive stretch. Go for it. That's going to stretch your intrinsics. I'm good with that. But ultimately, we don't really endorse those palliative care devices unless you're dealing with an extremely older person who may not be a candidate for surgery due to other medical comorbidities, or someone who may be younger who's not a candidate for surgery for those reasons. And that's actually whatever makes you feel better, although I honestly think that nothing will probably make you feel better than having adequate room in your toe box, adequate length, good cushioning, rubber sole, and you're kind of golden, and trying to avoid being barefoot if you're that easily triggered. When you are that easily triggered and all this fails and somebody comes in to talk about surgery, there are a lot of different ways to peel this carrot. And so I don't say anything about cats. You're a crazy cat lady. And I like cats. I think they're great in other people's houses. And the way to handle that is really to look at the functional range of motion, do the physical assessment like Dr. Collins was saying, and really, really paying attention to your x-ray. There are like 30 different types of procedures you can do to address a bunion. Just standard textbook things that you learn. I mean, 90% of them we're not doing anymore because they're old, but they are procedures that are out there and that in certain patients deserve consideration. They range from soft tissue procedures, they range from different types of what we call head procedures, and those are surgical procedures that are done up at the head of the first metatarsal. There are mid-shaft procedures, and then there are base procedures, including different wedging procedures and fusions with the medial cuneiform. Some of these things, like anything else in medicine, they come in and out of fashion. And I find that always a little bit disturbing that things become fashionable, because it's not like our bodies are evolving that quickly over time that in the past 100 years we should see as many surgical trends as we do. But a lot of these things are being influenced by the availability of different plating systems, screws, joint implants that are available commercially. And so what we tend to find, as disturbing as this is, again, sorry Instagram, that there are a lot of doctors out there whose decisions and surgical decision making are largely influenced by what's becoming available to them. And don't get me wrong, when something good and new is out there and it works well, it's a smart surgeon who adapts to that new technology and makes it available to their patients, in the right patient, always in the right patient. And there are people out there who are unfortunately doing one-size-fits-all surgery, which we know that you can't have one-size-fits-all shoes, you can't have one-size-fits-all physical therapy. There's certainly no such thing as one-size-fits-all orthotic therapy. How on earth are you going to do one-size-fits-all surgery? But we all know it. It's a sort of unspoken thing. That there are surgeons out there who, when someone gets a bunionectomy, they get a chevron osteotomy of the first metatarsal, period.
Or lapidus.
Or they get a lapidus. There is a surgeon at my surgery center, put it out there. There is a surgeon at my surgery center who only does a lapidus, even on patients with short first metatarsals. So you've got somebody who's got a foot that looks like this, they've got a really short first metatarsal, and now he's going to shorten it by another 4 millimeters. And then they want to know why these patients come back at 6 months and go, ow, second, ow, third. They get crazy transfer pain to the lesser metatarsus. And then he gets to do surgery on those. And we just start chasing it because the metabolic parabola was completely disturbed surgically and no one was dealing with that. There are a lot of people who do the same procedure over and over because that's what they're comfortable doing. And they assume that, like, oh, as long as you restore alignment of the joint, everything's good. Well, yeah, the primary objective of a surgical repair of a bunion is to restore the alignment of the first MTP joint, of the first ray, if there's an elevatus or if it's too plantar declinated, and making sure that you get good, functional, pain-free range of motion at the first MTP joint. But you also have to think about how that's going to impact the way that the rest of the foot, the ankle and everything going up works. And I think that that's often missed in the assessment and in the surgical decision making. Perfect example of one of the sort of newer forms of technology that works really well, that we've been having success with. No relationship, no conflict of interest here, just letting you know. There's a product called Cartiva. It is a joint implant system for very, very end stage hallux limitus rigidus. Like, there's no cartilage left, the bone on bone, you've got the ram's horn deformity, the patient has less than 10 degrees range of motion at the first MTP joint. And instead of doing one of the more radical penny or total joint implants, which are typically made out of stainless steel, medical grade, titanium, whatnot, you do a reaming out of the first metatarsal head. The implant sits in the head. It's sort of a silicone type based, but it's not silicone. I'm supposed to tell you it's not silicone. And it acts almost as a biological spacer in the joint that allows the bone on bone surfaces to basically glide against each other without bone on bone. Now, there are people who do this and they choose the right patient. We've had some really great success with it. And there are people who've come in where they've had this done, and it's very clear this should never have been offered to them because they weren't at end stage. But now you've reamed an entire crater into the first head, the head of the first metatarsal. There's very little you can do to undo that procedure. Mm-hmm. And more concerningly, if the patient had an elevatus, meaning their first metatarsal was elevated and that was causing jamming of the joint, there is no amount of putting in a spacer that is going to give you the range of motion back that needed to happen, because what needed to happen was an osteotomy to take that first metatarsal and bring it back down into alignment so you get better mechanics. And that's a perfect example of like new technology that's out there, but there are doctors I know
who are not using it correctly.
Who are using it indiscriminately because reimbursement's good on it right now. So again, there's the for-profit issue. You know, from our perspective, if you have a patient, physical therapy, if you have a patient that you're treating who has limited and or painful range of motion with a hallux valgus, hallux limitus deformity, and you are doing manual manipulations, you're doing sort of the standard loosen it up, try to get it moving thing. And they have pain relief during the session that then returns after leaving the session. That means that this is probably something that we could work with to stabilize either in some sort of shoe gear change or some sort of potentially orthotic, not necessarily for the long term, but while they're working with you on repatterning their gait. And that's the really important part of this, is really repatterning the way that they move. And that obviously has work that you guys are doing higher up the kinetic chain than what we're doing. But for somebody who isn't feeling relief while you're doing that, or like you have them on the table, you're doing some manual work, and then they try to get up and they stand, it's like, it's a little bit better, but it's not really feeling better. That may be that, like, hey, let's just send them over and get an x-ray and just make sure that there isn't something going on in that joint. There isn't a sesamoid fracture. There isn't an old sesamoid fracture where somebody misread as a bipartite sesamoid, which we've seen that before. And
there aren't any bony fragments in the joint itself, which
right.
we've seen several times.
Or they aren't developing dorsal spurs on the joint where the base of the proximal phalanx over here, where it hits the first metatarsal, they bang into each other and you get these little spurs that sort of lock against each other. That can be extraordinarily painful, and that's a form of hallux limitus that does not always present as visibly advanced, the way that you look at the foot and go, wow, that looks like, woof. Like, no, it's not like that at all, right? Well, that's what I always say. It's like, woof. But honestly, you can't tell from looking at someone's foot. I mean, I had a patient who came in yesterday who, like, it said on their bunion consult, she took off both shoes, and I took one look and I was like, wow, that's a big bunion. And before I even like said anything, she goes, it's not the big one. Big one doesn't hurt me. And I'm like, yeah, okay, cool. Didn't read the textbook. So let's see what's going on with the other one. And there were a lot of issues with that. As you guys know, and most of you I hope would probably glean from this discussion, our goal is not to do surgery, which is a weird thing for two people who love doing surgery to say. But if we can achieve a functional, pain-free, full unrestricted range of motion use of your foot without having to resort to surgery, that's a victory. That's the way we want to be treated.
Absolutely.
That's the way that we want to treat our patients. And so surgery, if we're making a recommendation for surgery, it's got to be pretty significant. And probably something that you're sending over because you know that this is something that like isn't responding to conventional physical therapy and isn't, or at least isn't responding as you would expect it to. I think we should shut up and answer questions.
Yeah. Thank you. That was great. So I have some questions about when you would refer to physical therapy. Are there some range of motion sort of criteria that you would have, or pain, or levels of pain, or how would you assess if a person is appropriate for a PT?
Sure. Do you want to do it? Or we probably have different answers.
Yeah. So I think that, if somebody comes in and they have got a completely arthritic joint where there is little to no motion there, that's something where if the goal is restoring motion, I always let them know that this is not going to happen. I mean, you literally have bone on bone. There's nothing we're going to do there. If I have somebody who is completely, or is a very active person, is a runner, and is having bunion pain or foot pain, that's automatically, for me, you're going to physical therapy. There's so much you guys can do in terms of gait analysis, running analysis, and then soft tissue mobilization and joint range of motion. So my answer is usually somebody who's athletic, who still has some range of motion, and has not seen a physical therapist before, they need to get in to see a physical therapist.
I would say that my assessment is probably nearly identical. I try not to make I shouldn't say never. I try not to make the pain level assessment part of whether or not they should go to physical therapy, because patients are really bad historians. And the one who, it's sort of Murphy's Law, I'm sure you found this in your practice too, that the patients who are complaining the loudest are not always the ones who have the worst pain or the worst condition, and the ones who should be complaining aren't, or they're really, really adept at living with high levels of pain, and they should be complaining. So I try not to let the noise of how painful this is affect my decision. I really go with, what am I seeing on physical exam? When are their symptoms exacerbating? And specifically, what am I seeing on x-ray? Because if this joint if you have an IM angle, an intermetatarsal angle, which is measured, it's sort of the baseline of a bunion, which is between the first and second metatarsals, and when that angle increases, well, it can increase here because this person has a very tight, deep intermetatarsal ligament. But when that angle sort of increases above 8 degrees, radiographically, we are done. You have a bunion. It's a hallux valgus. End of discussion. When I see that, or if I see an elevatus of the first ray or anything like that, and they're coming in with a complaint of first MTP joint pain, you're a candidate for physical therapy. End of discussion. Like, that's the way I look at it. I realize that I am the extreme opposite of most people in our profession. I'm sure that I'm far to the, I don't know if it's left or right of you on this, but like I feel like most people coming in with a foot problem have issues that are happening proximally, and that they need to be seeing a physical therapist. And that this is the kind of thing that requires PT like almost immediately. So that's not part of my functional assessment on whether or not somebody's a good, I think that most people in the city are a good referral for PT. They may require it. And if you have a symptomatic first MTP joint, like that's already a reason to go. The hard part is if the person doesn't really have a symptomatic first MTP joint. Case in point, I had a patient who had a bunionectomy that went bad. Different surgeon. Had a bunionectomy that went bad. The surgeon then went in and tried to address it in some way. And I'm being really vague here because I don't actually know the whole history, because the patient has proven, in retrospect, to be a very poor historian about what actually happened back then. And he was sent by a physical therapist to see me because he was having plantar second MTP pain forever and ever and ever. And this pain just wouldn't go away. It was being treated with ultrasound therapy by his podiatrist, who his PT was like, please just go get another opinion. We took a look at it. I'm like, I think you have a plantar plate rupture. He's like, yeah, I have one there at my second MTP. And he's doing ultrasound and shockwave therapy, and it's just not working. It's been like a year and a half, you might want to like do something different and expect a different result. And so, without calling them insane. And so he ended up having like a disastrously hypertrophic first MTP joint, which from the 2 surgeries, it was so gone, there was no joint, you couldn't visualize it. And there was a triangle fragment that had actually fractured off during one of his marathons into the joint, wedging it. So he had 0 degrees range of motion at the first MTP. And so, and everyone keeps saying, oh, you need a steroid injection, you need this, you need that. I'm like, your second MTP is tearing on the bottom because it's longer, because your bunion's been short, your first MTP has been shortened with multiple surgeries. And we need to restore range of motion at that joint, or else you're going to continually function like you have a fusion here and overload your lesser metatarsus. And ultimately, he ended up doing that, and we did a plantar plate repair of the second MTP. We also pulled that big fragment of bone out, and immediately his toe started to move. And then, because there was no cartilage left, he opted to have a Cartiva implant, and it's moving, and things are better. So, when you think about like pain and stuff like that, and this is somebody who ran Spartan right before coming into the con. I was like, okay, that's good. Yeah. Other questions? Yeah.
You've mentioned several times about PT role in up the chain assessment and intervention. When it comes to like interdisciplinary communication, I mean, I've been to your office as a patient. What types of things are you looking for from PT when it comes to assessment findings? You know, like obviously we're like, I think we're all on the same page here in this room, but worked with plenty of physicians who don't want to hear about hip range of motion. Like, patient doesn't have any hip extension, they're not using any push off up the chain, so it's all falling into, like, what kind of stuff is helpful for you guys to hear from us in planning interventions for the patient, like as a team. I've gotten emails from you that are really extensive and long that I appreciate.
Yeah, so we're the exception and not the rule, and that's unfortunate when we're trying to change that. Most doctors put it on the script and say PT 4 to 6 weeks, and and they're annoyed when you send your initial report because then they actually have to take 5 minutes out of their day, countersign it, and fax it back, and like that's not how we operate. We're very different. We want to stay actively engaged, obviously, as you know, with our patients and their ongoing care. Speaking purely for myself, although I imagine I'm not, I like to know everything.
Same.
Because I'm looking at the foot and the ankle because that is my area of expertise. But the foot does not live in splendid isolation at the bottom of the body. And just because the insurance industry in our society has segmented healthcare to a level where we have compartmentalized issues. So a problem with my shoulder, I see a shoulder orthopedist versus a problem with my knee, I see a knee orthopedist. It doesn't mean that there shouldn't be interdisciplinary communication because it's all one big chain, right? And it's all one moving system. And so if you take a systems approach to what's happening in your patient, I need to know what's happening with their hip. I'm looking at their hips and their knees. I'm looking at pelvic movement when they're walking. Our gait exam is very thorough. We really look at the whole thing. People always laugh when they do a gait exam. They go, "What's going on with your shoulder?" And they go, "What?" You go, "Is it hurting you?" And they're like, "Oh, it always hurts." It's like, "Oh, okay. Well, now we know why things aren't moving at your hips. That's cool." Because you're like splinting, so you're walking like a linebacker, just like locked in place. And your hips won't move because you won't swing your shoulders. And like you try to explain this to them and their head just goes, you see the smoke coming out of their ears. So what's good for us, for myself, speaking purely for myself, the more information you give me, the more I can sort of figure this out. The more information I give you, the more you can figure out. So it puts a lot of extra work on us, but it's worth it.
I think included in that would be anything that you guys have tried, how they have responded to that therapy, and also I always appreciate input, what you think that they would benefit from. But same thing, I'm in alignment with you. As much as possible is good, especially how they have responded to what you have done.
And just with that information, I've seen how patients love that you both, or we're all talking so much about them. They feel that we're really taking care of them and just not that one line.
Well, that's part of the added value I think that we offer, specifically in the kinds of care that we give our patients. We're not just sort of taking a transactional approach to PT or to their office visits with us. It's really a commitment to an outcome and staying with them through a process. And that ultimately, I think, is what gets people well and gets them to stay well.
As far as surgery goes, after you do like a chevron procedure, do you expect? I've heard different expectations. Sorry, the cops are coming. We can just give him just a few seconds. Yeah, what did we do?
Clearly, I've been spilling secrets here.
I've heard different expectations for post-op range of motion. The most common was, and from the literature, is 35 degrees of extension. Is that something that I've always been curious about? Why only 35? I mean, I know that. Is this true? But with that procedure, you basically snip the adductor hallucis, right? Does that have something to do with why you would only keep it at 35?
So,
as opposed to like.
Again, just you don't always snip the conjoint tendon of the adductor hallucis tendon.
Okay.
That is part of the procedure that is referred to as a lateral release, and some people do it, some people don't.
Oh,
I was
didn't know.
I was trained that you just do it.
And I would
yeah, that's
say
what I-
that you don't always do it.
Right.
Okay.
And so like,
Oh,
and that's the
okay.
difference between like 15 years of education. So it's changing in
That's
a,
great,
in
yeah.
a good way, which is great.
Yeah.
When I got out to practice, I would realize that like when I'm in the middle of surgery and I'm at the point where I need to do a lateral release, and I take their big toe and I pull it over and like they could hitchhike with that big toe.
Yeah.
I'm like, why am I
Why would I release this
sacrificing
more? Yeah.
this tendon? This is
Right.
crazy. There's
Yeah.
no reason for this.
Yeah,
Similarly, there are a lot of people who are trained. I'm curious where you come down on this. The hallucis brevis tendon. Do you release it?
Not always.
Good, because I was taught that you're supposed to release it. Except somebody who was my mentor in my residency, Larry Silverberg, was like, you don't need to do this all the time. This is an old way of doing it. And thankfully he taught me that. And I just was like, no, actually I'm going to try to maintain as much of your normal anatomy as I possibly can. It's like we're trying to get in, fix what needs to be fixed, but leave what doesn't need to be fixed alone. So I just wanted to address that part of your
Yeah, because
question.
I was curious. Yeah, I was just,
But that very well may be
Mhm.
an accounting of why 35% of extension is what you can hope for postoperatively. I think that honestly, the data behind that number,
yeah.
I'd question where it comes from because
Okay.
I've never understood it, and I can tell you that from my own 15 years of private practice experience that in patients who have a really, really excellent range of motion to begin with, you can expect really excellent range of motion postoperatively. Like I have patients who've had really painful bunions that didn't respond to all conservative care, who opted for bunionectomies, who, by the way, going in that day had 65, 70 degrees extension on that joint. And when we're done with surgery, they've got 65, 70 degrees range of motion on that joint. Or I've seen ones where it stiffens up because maybe they didn't do their PT and they get capsular hypertrophy and they get some scar tissue and so they only get 50 degrees. Okay, I'll live with that if that doesn't impact the way that you're moving. There are people who have, like, you look at their good foot that doesn't have a bunion and they've got a solid 30 degrees range of
Yeah.
motion. You're like, well, okay, so there's something else going on here. By the way, their ankle joint doesn't go quite to 90. And so I think that there's a lot of opportunity for research in this, frankly. I think there's a lot of anecdotal information, but I don't think it's been properly studied.
So would you say you also, in general, don't adhere to like hard and fast rules when it comes to post-op protocol? Like, there's no cap on how much range a patient should achieve, just patient by patient, case by case.
Yeah, for me, it's always patient because
It
we were
is.
saying
Procedure.
earlier, every foot is different. Every patient is different.
And the only thing that I would say that there may be a cap on is excluding like end-stage hallux limitus, hallux rigidus, where clearly they have like no range of motion left, or no pain-free range of motion, I should say, left. But I think you're really looking at saying, I want you to at least have the bare minimum of like 15 to 20 degrees that you need to function. If I can't give you that, then why am I doing the procedure? But beyond that, if you've only had that, and your good side, which is of course not a one-for-one comparison, but your good side is severely limited as well, then I think you shouldn't expect that you're going to get more than like 35 degrees range of motion out of them in the end.
Probably have a question for one, maybe two questions. More time for two questions. Brittany is from a Pilates instructor.
We actually share.
We do, we share.
Oh, that's true, yeah.
Okay.
We go way back.
Yeah.
Okay. Cool. Yeah, I don't know if how have you heard about patients who choose to just kind of do rehab through Pilates or post? Yeah.
I have a lot of patients who choose to, we have a couple patients in common who have chosen to work with you instead of with a physical therapist. And depending on what they're working on, I think it's totally fine.
Yeah.
Depending on what they're working on, it's completely inappropriate.
Sure.
And thankfully, a good Pilates instructor will tell them like, you need to be doing physical therapy in conjunction with Pilates. I know that like when we've done PT together and you're incorporating of the reformer into some of the work that we were doing, actually was really, really helpful for me. I think it's like anything else. There's a lot of really good overlap. and there are areas where Pilates can actually do things for the person that maybe they don't get to do in traditional PT. And I think that there's things in PT that people just cannot possibly achieve during Pilates because they're different animals. Yeah, I think Pilates is hugely complementary to PT, and I think that it's particularly when you're talking about trying to restore balance, strength, range of motion. That's what Pilates is about, in my experience.
Well said.
Thank you.
All right. Well, I'll wrap it up just so we can all chat and everything. Thank you, Instagram fam. Thank you guys very much.
It's like Michael and Tracy. So hi,
Yeah.
Michael and Tracy.
Hi, Shelby. All right. All right. Bye, guys. Thanks.